treating cervical myelopathy. Ed,
Well, thank you, Nikolai. How much time do I have?
as much as you want.
Okay, that's a dangerous thing to say to me. Um, so I'm looking for my share button here. Share, got it. Okay, can you see my slides?
Yes, all good, all good.
Okay. Well, I'm not talking specifically about trauma today, but I am talking about cervical stenosis and cervical deformity as it relates to cervical spondylotic myelopathy. And I'm going to talk to you and try to present my learning curve over the past 2+ decades in managing these patients. Let's see. So cervical spondylosis basically presents to us as physicians as myelopathy and deformity, and CSM, cervical spondylotic myelopathy, is caused by one or both of two factors, encroachment and tethering, or repetitive trauma. Each of these individuals has two things in common. First of all, they have a cervical deformity, and they all exhibit what we call the kyphosis trapezius sign, which is a tense trapezius muscle. The trapezius muscle is an accessory muscle of extension, and when extension isn't allowed by a fixed deformity, it is reflexively activated, causing significant myofascial pain, oftentimes for the patient. But these patients often have back pain as well. This is a lady who had an occipital to thoracic fusion for reasons that were not clear to me. But bottom line is she was fused with her head in a slightly flexed position. So in order for her to maintain balance, she has to lean backwards, as you can see here on her scoliosis view, and thus puts a lot of stress on the facet joints and the intervertebral disc, causing back pain. Here's another example of a patient with a kyphotic deformity, the kyphosis trapezius sign, and in order to see forward, this lady has to lean backwards, causing significant lower spine pain. There are a variety of non-operative strategies for this problem. One is postural, having the patient gradually put their neck in an extended posture, as in the lower left. This is a patient with ankylosing spondylitis on the right. And now we have biologics to help treat this horrific disease. But had we known decades ago that if we just put the patient in a more extended posture and have the patient not sleep with a significant pillow, then he might not have developed this horrible deformity. We can do strengthening of the muscles with a variety of exercises. This one is probably the best, having the head push backward against the hands pushing forward, working on the strength of the erector spinae muscle, trying to, in an attempt to offload some of the stresses on the erector spinae muscle. Surgical strategies are basically fall into two categories, ventral and dorsal. We do know that from Zogo Gowala's work, that the more we correct the deformity, in other words, diminish the SVA, sagittal vertical axis, for example, as in the right upper picture, the more we're going to treat the symptoms. If we have a posture that we end up with that looks like the lower right photo, we're going to have problems with a lot of pain. This is a patient I operated on in her early 50s. She had these flexion extension x-rays and cervical stenosis, and I did a laminectomy and a cervical fusion. This was early in my 2-decade journey, and it was a mistake. Of course, her myelopathy improved, but she's left with a fixed deformity, essentially, of a straightened spine and a relatively significant SVA. And she has quite a bit of neck pain that I caused her to have. So we need to, we obviously could have gotten her into this position because this is an extension x-ray, but I didn't, and I didn't work hard enough at it. And she taught me that I need to work harder at and be more aggressive regarding corrective intraoperative deformity. A way to help with this is to use a frame that may have ropes coming off. And if you have the rope, which is attached to a Gardner-Wells tong, come up over the top of the bar, you can pull the patient into extension like this. My problem with this, having used this technique only a couple of times, is the unnerving nature of the dissection, because the head bobs up and down while you're trying to operate, and always in fear that this tong will slip. Yes, we have a fail-safe here, but I don't know that I completely trust that. And here's another picture of the same thing. At any rate, we need to focus on deformity. Why? Because we can diminish neck pain, as I've just mentioned. We can improve myelopathy, decrease end fusion degenerative changes, and improve short and long-term outcome. Intraoperatively, deformity can be corrected ventrally and dorsally, and it's all about leverage. Ventrally, we can use cast bar pins placed convergently and then straightened out to help correct deformity. We can leave an intervening vertebral body and bring the bone to the implant to correct a straightened spine or a kyphotic deformity. This is depicted here by placing screws at the upper and lower ends and gradually tightening the inner screw or the intermediate screw to attain a lordotic posture. And here we see an example of such. We can use gravity as our friend. There is a phenomenon known as viscoelasticity, which is a gradual deformation of a body under a constant load. So this is a patient that I took care of about 20 years ago. She had multiple prior operations, laminectomies, anterior cervical fusions, etc. She had the kyphosis trapezius sign and progressive myelopathy. We can see here that that she has signal changes in her cervical spinal cord. By the way, can you see my arrow?
Yes, we can see it, Ed. Yeah.
Okay, great. I'm making sure because it's important. So she's got a signal change in her spinal cord, but at the area where she has her signal change, there is no significant compression. She has patent ventral and dorsal subarachnoid space. So we knew we could correct her ventrally because her facets weren't ankylosed, as depicted here, except at that fusion site, and we got quite a bit of extension at the below the level of the fusion, as implied by the fish mouth appearance of that disc interspace. So we put her on an operating table with a log roll under the shoulder and a donut under her head. We did some dissections, etc., and then took the donut away to allow her head to move dorsally, and thus gradually correcting deformity. This does not happen right away. It takes time. should I do something? It said recording stopped.
Ed, please continue.
Okay. So we let her head fall backwards, and you have to be patient when using these strategies because it takes time for the ligamentous structures to relax and stretch. And basically, we gained with her or got her to a 15-degree, a 5-degree lordosis, converting her from a 15-degree kyphosis. It's all, it's all about leverage. Um, in the prone position, we can readjust the head holder. And in my case that I presented earlier, I obviously did not pay enough attention to this. It was an incredible lesson learned for me. But fixation follows, and then you hold the patient in this position. Of course, with this lady, we could have done an anterior approach and a posterior approach, but doing 2 operations versus 1 operation in a person who's not in the best of health can be problematic. And so I try to do these cases with 1 operation when possible. Again, with her, we brought the bone to the implant. And here she is post-op. Her spinal cord looks great. There is no signal change. And she improved significantly with regarding her myelopathy. Here she is pre-op, and here she is post-op on the right side. We didn't know too much about this at the time, or at least I didn't. But what is obvious now is that we stopped the trauma. She was repetitively traumatizing her spinal cord, causing an injury or a bruise, if you will, in the spinal cord. And by stopping the trauma, we allowed the bruise to heal and her function to improve. So causes us to scratch our head. Then about a year later, another fellow from Puerto Rico comes along, having had 10 years prior a laminectomy for cervical spondylotic myelopathy, from which he improved significantly. And then he began having a progressive myelopathy again, and his physicians got this MRI, which demonstrates no compression, an atrophic spinal cord. And so we said, well, what is going on here? Well, let's go back to the principles that I talked about. Cervical spondylotic myelopathy is a manifestation of repetitive trauma and tethering and distraction. So we got flexion extension films, and we see that because of her arthroses in the facet joints, she can't extend all the way, but he can't extend all the way, but he can flex as depicted here. So again, this is over 20 years ago. We, at least in our hospital, for the first time, got a dynamic MRI scan. We got flexion extension views, and this is what we saw in flexion. This area here is probably a cervical post-laminectomy band, if you will, but regardless, his spinal cord was compressed substantially in the flexed position, thus illustrating the point that repetitive trauma plays a major role in cervical spondylotic myelopathy. Neutral position and a flex position. We knew we could correct dorsally because we could relax and release the facet joints, and none of them were fused. They were just arthritic, I guess, and wouldn't allow extension. So we did multiple facet osteotomies, and I'll explain this a little bit later, but it basically, an osteotomy involves removing all of the bone all of the way out so that you totally free up the joint and then put the patient into the position you want, things usually turn out well. Well, for this patient, he introduced another concept, the C23 joint being a potential pitfall for the management of these problems. And we fused him from C3 to the thoracic spine, leaving the C23 joint unfused. And the facet capsule had probably been disrupted by either or both of the operations. Plus, as we have subsequently observed, the facet angle, the angle of this joint, is not parallel to the floor in the standing position. Here's that angle. And so he was treated back home with a fusion, and they still didn't get a completely horizontal to the floor C23 joint, but they fused to C2, which relieved the majority of his symptoms. Another patient had a C7T1 disc herniation. Now we're getting up to about 15 years ago. And he had this contraption placed for a disc herniation. Because he had a lot of neck pain, the surgeon took this implant out and gave it to the patient, and he reconstructed it so I could look at it. But he's left like this. He's got a kyphotic posture. So his MRI doesn't show any compression. He doesn't have any myelopathy. But look at his posture. Look at his kyphosis trapezius sign. His back is hyperextended. So he's got neck pain and he's got back pain. And we did facet osteotomies and then turned him over, used trapezoidal allograft fibula. We brought the bone to the implant and created a lordotic posture for his spine. And now look at his neck. Compare pre-op with post-op. So we have effectively treated his kyphosis trapezius sign and his back pain by simply putting him back into his normal lordotic posture. Sometimes we need to correct at a different level because of anatomical restrictions. This is a lady with neurofibromatosis and dural ectasias, and a ear on shoulder deformity, if you will. You can see prior surgical misadventures here with a clamp. And she basically was fused from occiput to T2 with a significant scoliotic focal deformity. Having said that, we knew that it would be very difficult to re-engage that area. And so here's her dural ectasia, vascular ectasia. She also had dural ectasia. And here's that Halifax clamp. And here she is pre-op. And at the time of surgery, we put her prone and her head was tilted to the left, or to the right, excuse me. And then after we had partial facet osteotomies performed, I broke scrub, went down below the table and put her head in the straightened position as you see in the middle picture, and then finished the osteotomies. Now, an unnerving thing happened during this osteotomy here, and that was we heard an audible pop with a sudden correction of the deformity as we got through the last ligamentous and bony confines of the deformity. And one should be cautious, and the patient should be aware that there could be a vertebral artery injury under such circumstances. And there wasn't, and people comment about looks like screws are going every which direction. We must remember that our job is not to make the post-op x-ray look pretty. Our job is to take maximal advantage of the anatomy that's presented to us. And so these upper two screws go through lamina and fusion masses, and the rest of them are facet screws. And here she is post-op with a CT reconstruction. Pre-op on the left, post-op on the right. This lady had multiple anterior and posterior operations, and a progressive myelopathy. And we decided that she probably would benefit from surgery, but felt that we really would like to do her from a dorsal approach. We got a CAT scan and we see significant disruption of bony elements and lack of integrity of them. But this is the reason why we really felt that an anterior operation was not in her or our best interest. And so we put her in the prone position on the operating room table. And this was in the days before the O-arm or intraoperative imaging with CT. And we could, on X-ray, we could see down to the mid C2 vertebral body, and we had no idea how much correction we had. And so we took her to the recovery room and then the ICU, left her in traction with a roll under her shoulder. And then several days later, took her back to the CT scanner and got this image, which we felt was adequate. And so we said, we'll take this and we'll fuse her in this position. We used lots of screws, went way down in the thoracic spine because we were concerned about the weight of her head and the stresses they would apply. Let me go back here. And we did facet osteotomies at multiple levels. And these videos don't work, and I apologize for that. But this illustrates a facet osteotomy. We went all the way through. And people say, well, what about the nerve root? Well, the nerve root's always going to be dorsal to the vertebral artery. And if you get down to the nerve root and stay behind it, you should be fine. But you should also be cognizant, looking at preoperative anatomy on CT or MRI, of any anomalies of the vertebral artery, because it would be devastating. It would be devastating to get into the vertebral artery here. And so here she is post-op. And she was happy. She lost some weight for a while, but then gained it back. So I'm on the downswing here. What I basically suggest is that we need to pay attention to the C2-3 angle. If we keep it horizontal to the floor in the standing position, we can decrease reoperation rate, pseudoarthrosis rate, progressive kyphosis rate, and then adjacent segment degeneration and disease. And we reported this in 2018 in Journal of Neurosurgery. But it's also important to remember the T1 slope, or the C7 T1 angle. This patient, interestingly, has a cervical lordosis, but she has a significant sagittal vertical axis because she's got a cervical thoracic deformity, and that needs to be addressed, not just focusing on her upper cervical problem. So the C2-3 angle to me has intraoperative utility in determining when I am done and I have adequate correction. And the T1 slope tells me what I need to do. This is a lady who has had multiple operations and has a significant cervical pain. We did facet osteotomies, took out old hardware, added new hardware, took her fusion up to C2, and here she is. And we got a prone X-ray in the operating room, and we see that C2-3 looks like it could be perpendicular, parallel to the floor when she stands. If we just take the X-ray and turn it 90 degrees, we can see that we've done fairly well with her correction, and we decided to take that. Here she is pre-op and post-op with a correction of her C2-3 angle. Note that in so doing, we moved the plumb line ventral to her old lumbar fusion. The problem, that's not a problem, because it's probably normal considering that she's had a prior lumbar fusion. And we see here that in order for her to look forward with her head kyphosed, she does need to lean backward. And that was relaxed with her operation. One last case, a 34-year-old male with a neuropathy, small fiber neuropathy, with this deformity, 34 years old. So please keep that in mind. He's got a little compression here with the MRI scan, but this is what he looks like, and his complaint is neck pain. We did a C4 and C5 laminectomy with bilateral foraminotomies and C2 through 5 instrumented fusion. I had multiple partners tell me I wouldn't be able to get away with this. But I said, he is a young guy. He's going to have a mobile spine. So we put screws into the C2 to C5 levels and then simply pushed the spine forward in the middle and engaged the screws, which we had already placed. And we left him with this posture. And he started with the posture on the left. And we can compare pre-op and post-op. And he was a very significant happy camper or happy patient. And this has been sustained for several years. I emphasize getting scoliosis views. I think they can help us determine how the spine is stacked up, for example, with the lady that I just spoke about. And please keep in mind the literature on end fusion degenerative changes. They occur mostly not because of excessive motion, but because of abnormal posture. The abnormal posture then causes progressive degenerative changes. And so we need to focus on deformity, focus on the C2-3 angle, and a simple every operation is a deformity operation. You can either treat a deformity, prevent a deformity, or cause a deformity. And these two patients had an ACDF operation with an instrumented fusion. I can almost guarantee you that this patient whose focal alignment was left in a relatively normal lordotic posture will fare better than this patient who was left with a kyphotic deformity, which places significant stressors on adjacent segments. Thank you very much.
Thank you so much, Ed. It was a very good review of everything that we have to look into when we are treating our patients. We should focus and see the global picture, not only when we look at, as somebody says, when we look, we should not try to look the leaves, but we have to go back and see the whole tree and the forest as a whole.
I couldn't agree more. That is why the scoliosis view is so important. As you just said, we're kind of looking at the forest, and getting the big picture can be very helpful.
Yes, that was great, and we are really thankful for your participation and for taking time to speak.